I'm Jocelyn from Manly General Hospital, Myanmar. I'm talking about is there any role of thrombolysis in AMI? If someone asks me this question, my answer is yes, definitely yes for low and middle income countries, and still yes for developing countries. As we all know, STEMI is caused by acute thrombotic occlusion or epicardial coronary artery. Aims are to prevent the death, to limit the myocardial damage, to minimize the discomfort of the patients by providing reperfusion therapy either mechanically or pharmacologically. We have known that the improvement in mortality from 30% to 6% by giving reperfusion therapy from pre-CCU era to reperfusion era. But reperfusion therapy should be prompt, but it improves the patient's outcome. According to wavefront theory, the longer the duration of occlusion of the coronary artery, the larger the damage of the myocardium. So the reperfusion should be very quick. There's a golden hour. We can save 65 lives for every 1,000 patients treated with thrombolysis in the first hours. So not only prompt, the reperfusion therapy should be complete to achieve high TB3 flow and myocardial perfusion grade 3 flow. That will improve the patient's outcome. So ideal reperfusion should be rapid, complete, sustained, and less complications. So there are two different types of reperfusion strategy, pharmacological and mechanical. Let's see fibrinolytic therapy. So there are several agents for fibrinolytic therapy that can be used either IV bolus or infusion. In ISIS-2 trial, streptokinase and aspirin reduced 35 days vascular cause mortality from 30% to 8%. In GISI trial, the same, IV streptokinase reduced 21-day hospital mortality 10.7% compared to 30% in placebo. Gastro trial proved that TPA is better than streptokinase. So overall, fibrinolytic therapy improved mortality with slight increase in stroke and major bleeding. However, the mortality benefit of fibrinolytic therapy will be lost if it was given over 12 hours of symptom onset. So fibrinolytic therapy that can be given very easily, available in most hospitals and ED, good efficacy in the first 3 hours. But there are some relative contraindication. We cannot use thrombolytic therapy in some patients. So how about primary PCI? It is a reperfusion method of choice, but can achieve high rate of TB3 flow more than 90%, that improve outcome in terms of lower 30-day mortality, lower death and non-fatal reinfarction, and lower rates of stroke. This meta-analysis comparing 23 trials of primary PCI and fibrinolytic therapy. Primary PCI has lower death, reinfarction, stroke, and overall combined endpoint compared to fibrinolysis. However, primary PCI has some problems. The primary PCI is a treatment of choice that's only given in time. So, however, in the real world, all STEMI patients may not be able to receive primary PCI in developed countries as well as developing countries. Most of patients live in a rural area. They may not arrive PCI center in time. Even in the United States, primary PCI can be performed only 25% of acute care hospital. So even patients reach the hospital in time, they may not undergo primary PCI. So more than half of the patients, half of the peoples globally live in rural area, same as in our ASEAN countries. So moreover, there are some obstacles for primary PCI for developing countries. In rural area, no cath lab, no EMS, no STEMI network. Even there's a cath lab 24/7 around, facilities not available, less number of trained interventional cardiologists. In some countries, they adopted cost-based healthcare system rather than value-based healthcare system. So in that situation, pre-hospital thrombolysis could be the most feasible strategy. So many cities around the world, traffic jam. So ambulance cannot get up on the traffic jam. So we know that the primary PCI is better than fibrinolytic therapy, but that depends on door to balloon time. The longer the door to balloon time, the higher the mortality. So PCI-related time delay versus mortality benefit in this trial. So mortality benefit from primary PCI may be lost if door to balloon time delay by more than 60 minutes compared to door to needle time. So every 30-minute delay will increase 7.5% 1 year mortality. Not only that, thrombolysis can be performed equally during regular hour as well as the out of office hour. But for the primary PCI, the door-to-balloon time will be more longer in out of office hour compared to regular hours. So the advantage of PCI will be lost if door-to-balloon time minus door-to-needle time is more than 114 minutes. So even primary PCI is a preferred reproduction strategy. The limited availability of primary PCI centers, outcomes depend on expertise, operator expertise, and if 2 or 3 STEMIs arrive hospital at the same time, there will be delay for door-to-balloon time. So in such cases, farm-going-basis strategy should be alternative. So it is class 1 recommendation in ESC guideline and class 2A indication in American guidelines. So in PAMI trial, PCI followed by fibrolysis will achieve higher TME3 as well as population grade flow. So if we want to overcome these delays, door-to-needle time and door-to-balloon time, we should adopt pre-hospital thrombolysis and hospital transfer for pharmacoinvasive therapy. So pre-hospital thrombolysis has more MI abortion compared to in-hospital thrombolysis. In French nationwide registry, pre-hospital thrombolysis is even better than primary PCI in terms of age-related survival. So we need pharmacoinvasive strategy for socio-economic reasons, country-specific healthcare resources, practices, and policies, non-patient-related factors such as transport conditions and location and availability of PCI capability. There are several studies supporting pharmacoinvasive strategy. Almost all trials supported pharmacoinvasive therapy is non-inferior to primary PCI. In some study, pharmacoinvasive strategy is even better than primary PCI. 3 registries supporting pharmacoinvasive strategy. In BNL registry, if thrombolysis can be given 2 hours of symptom onset, that is better than primary PCI. In Manipoli's strategy registry, the pharmacoinvasive strategy is equally safe and effective compared to primary PCI. In French registry, comparing 3 different types of reperfusion therapy, thrombolysis and primary PCI has a similar 5-year mortality. So this meta-analysis comparing 5 different Asian Pacific countries, all country has similar infrastructure and 24/7 primary PCI availability, but in Malaysia, majority 72.6% of STEMI still receiving fibrinolysis compared to 91.6% primary PCI in Korea. So this study done at our hospital comparing primary PCI and pharmacoinvasive using streptokinase. So both groups have equal in-hospital mortality and slightly increased minor bleeding in pharmacoinvasive group. So in India, every year more than 3 million of STEMI, but less than 10% of STEMI patients receive primary PCI. Although there are many hospitals with primary PCI facility, there are several reasons for delay to getting primary PCI. So STEMI India, they adopted STEMI India model to get optimized reperfusion therapy for pharmacoinvasive strategy. So they use spoke and hub model. So in India, in 2030, the consensus statement suggested for STEMI patient symptom duration less than 6 hours, fibrinolysis followed by PCI is suggested. So in 2017, both fibrinolysis and primary PCI are class 1 recommendation for STEMI with 12 hours of symptom onset. So this latest 2020 meta-analysis comparing thrombolytic, primary PCI, pharmacoinvasive, and facilitated PCI on 31 eligible articles. According to multivariate network meta-analysis, primary PCI is preferred treatment for STEMI. When primary PCI is not available as a reperfusion therapy, pharmacoinvasive approach is superior to facilitated PCI and standard fibrillary therapy in terms of mortality, stroke, and major bleeding. So that will guide better design or stable system of care across the diverse healthcare system. So, ladies and gentlemen, not only PCI, primary PCI and fibrolysis, there are one more new repurposing strategy, that is pharmacoinvasive approach that will improve patients' outcome. So, the choice of repurposing therapies depend on patient orientation. It's not possible to say definitely which repurposing therapy is better than other. The appropriate and timely use of repurposing therapy is more important than choice of the therapy. So, pharmacotherapy